introduction of the speaker by Dr. Sajid.
Good evening, all. We have a good number of critical care specialists in Aster Mims, and their primary degree vary. Some of them are physicians, MD medicine, some of them are pulmonologists, and some of them are anesthetists. And Dr. Sajid is a very efficient and eminent consultant in the Department of Critical Care Medicine, and he's had his MBBS from Coimbatore, then DNB in pulmonary medicine from Hyderabad. Then he had his advanced training in critical care medicine from Aster Mims, Kozhikode. And he worked over there and then joined our institution. And he leads the various programs in the critical care medicine. And he was instrumental in various programs like extracorporeal oxidation program, etc. And that's all. We'll listen to Dr.
Good evening, everybody. First of all, I'd like to thank all the office bearers and all the participants for giving me a chance to make this presentation over here. My topic for today would be initiation of mechanical ventilation. I would be touching only the initiation of mechanical ventilation, the very basics, so that after this class, you would have some idea how to start off a mechanical ventilation and what parameters to set in and what is the rationale behind setting these parameters. The objectives of today's talk would be, first, I would like to define what is mechanical ventilation. As you all know, mechanical ventilation is a shift from our intrinsic negative pressure ventilation to positive pressure ventilation. So what exactly happens in positive pressure ventilation? When do you decide, or the indications to start off mechanical ventilation? What are the very basic modes of mechanical ventilation? The first settings that you would start off once you ventilate a patient, and the general care while on mechanical ventilation. The gentleman on the right happens to be Andreas Vesalius, who had the first scripture on mechanical ventilation back in the 16th century. By definition, mechanical ventilation is the delivery of positive pressure to the lungs via an endotracheal tube or a tracheostomy tube. As you all would know, our body is basically a negative pressure ventilation. The extreme negative pressure in the intrapleural space is what allows inhalation. And that is how the normal breathing happens. But in mechanical ventilation, it is a complete shift from negative pressure ventilation to positive pressure ventilation. There is a predetermined mixture of air and oxygen, which is forced into the alveoli, which leads to an increase in intraalveolar pressure. A termination signal happens either in the form of volume or pressure or time. The supply of air stops and expiration follows passively. When would you decide to start somebody on positive pressure ventilation? I would rather divide this into two parts, lung and non-lung causes. The first cause happens to be mainly in neurological patients or in patients with a bulbar palsy, wherein you feel that your airways are unstable or unprotected. They continue to aspirate their secretions. You have the gurgling noise happening. They have progressively worsening or increasing O2 requirements. In these patients, you end up intubating the patients for securing the airways and to reduce the risk of aspiration. The second most common condition happens to be our conventional cause of ventilation, that is your ARDS or pneumonia patients, where you have a hypoxic respiratory failure and your main aim is to deliver a certain amount of oxygen and to maintain the oxygen targets of that patient. This is hypoxic respiratory failure. The main conditions being ARDS and pneumonia. The third condition would be hypercapnic respiratory acidosis. What happens over here is somebody who's not able to maintain his ventilation, that is, his carbon dioxide levels are too high. You would want to reduce the work of breathing for him and to improve the respiratory fatigue that is set in. Once somebody is breathing at, let's say, around 35, 40 breaths per minute, your normal breathing rate is around 12 to 18 breaths per minute. At one point of time, he would give away. His respiratory muscles would give away and he would start to develop fatigue. Once the fatigue happens, naturally, the oxygen levels come down, the carbon dioxide levels come up. So to prevent this fatigue or to reduce this fatigue, to reduce the work of breathing, you would like to initiate somebody on mechanical ventilation. Other more lesser common procedures happening to be bronchoscopy or bronchial suction, where somebody who's got hypoxic respiratory failure, it is not possible to do a bronchoscopy or bronchial toileting for a patient. You would facilitate bronchoscopy by intubating the patient, get the bronchoscopy done, improve his lungs, and then extubate him off. Sounds simple, but it's not so easy. Like I told, we are creating a dynamic shift from negative pressure ventilation to positive pressure ventilation. Now, what would happen if you start somebody on positive pressure ventilation? What's going to happen? Naturally, when I start somebody on positive pressure ventilation, all the positive pressure is going into the thorax. All the return that happens from our legs, from a lower body, everywhere it comes back based on the pressure dynamics in the thorax. Now, if I put somebody on positive pressure, I increase the interthoracic pressure, don't I? Now, when I increase the interthoracic pressure, your venous return decreases. Once the venous return decreases, the blood that is filling the right ventricle decreases. Naturally, the amount of left ventricle will only pump out the amount of blood that is reaching the right ventricle. So there's a decrease in venous return. So one thing that you can expect is once you put somebody on positive pressure ventilation, the LV outflow reduces, a decrease in cardiac output happens, and a hypotension can happen. This is one of the biggest heart-lung interaction that happens once you start somebody on positive pressure ventilation. The second thing is, again, positive pressure. All the brunt of the positive pressure is supposed to be taken up by the lung parenchyma and the airways. This is what would lead to a ventilator-induced lung injury in the form of barotrauma. The second thing that can happen is air trapping. I wouldn't talk about air trapping right now. I have other slides coming up which could explain air trapping better in the coming slides. Third thing is gas exchange. Now, what happens is when you give positive pressure, you end up opening up your alveoli. Now, there are always vessels underlying the alveoli. Once you open up the alveoli more than what is required, it'll end up in compression of the capillaries around the alveoli. So what would happen? There would be no diffusion. Once the alveoli gets inflated more than what is required, it ends up compressing the capillaries and it impedes the diffusion. So you might end up, if you don't put up the right pressures, you might increase the dead space. And that would also lead to shunting. This is a flow chart of how the effects of mechanical ventilation happens in the interthoracic space. You would increase the interthoracic space. Like I said, the alveoli get inflated and they end up compressing the pulmonary vessels, and that will lead to increased pulmonary vascular resistance. It would also lead to decrease in RV return, decrease in venous return. Ultimately, what happens is there will be decreased RA filling, decreased RV preload. Because the pulmonary vascular resistance increases, it might lead to increased RV after also. So ultimately, what it leads to is the right ventricular stroke volume decreases. Now, the LV will only be able to pump out what the RV gives it. Now, if the RV stroke volume is decreased, ultimately, the cardiac output decreases. Okay. Now, in this situation, if it happens in somebody with a heart failure, look at the right side of the slide, you find that there's also a decrease in now, if you decrease the amount of blood that is going into the heart in the LV work also reduces. So this is how ventilation helps in patients with heart failure by decreasing the LV afterload and decreasing the LV work also. Okay. Now, after the effects of positive pressure ventilation, now what initial mode do you set in? I'll just talk about the most common modes and then where and how total tabular column to tell you about all the modes in together. there is no universal initial mode of mechanical ventilation. There are multiple trials being done all over the world, pressure control ventilation, volume control ventilation, APRV, all these modes. No mode has been found to be better than the other mode. It is always, in critical care, we all work as a team. There's no one-man show, there's no superhero in critical care. So whatever mode your team is well efficient in and they know in and out, that is the accepted mode. Okay. And the most common modes that are used are the volume control and the pressure control modes. Our unit is very much accustomed to volume control mode, so we use volume control mode. There are particular indications where we tend to use pressure control mode, but those are very specific indications. So the crux is whatever your team is comfortable in, that is the mode to be used. And the third mode happens to be the synchronized intermediate mandatory ventilation, or the SIMV, which is slowly being pushed out of favor right now. So for historical purposes, there was something called the control mandatory ventilation. Now the control mode of ventilation is when, like the name says, everything is controlled. Nothing is, the patient is not allowed to do anything. He wouldn't, even if he wants to take a breath, he will not be allowed to take a breath. So control mode of ventilation is wherein there's a preset tidal volume at a time triggered respiratory rate. That is, you keep a tidal volume fixed, let's say around 450 ml. The ventilator will give the 450 ml. If you keep it, let's say a respiratory rate of around 30 breaths per minute. So 60 seconds is what consists of a minute. So you will have a breath given every 2 seconds. That is what a preset tidal volume and the time triggered respiratory. So the trigger happens to be every 2 seconds over here for a volume to be delivered. Patient cannot change his respiratory rate or breathe spontaneously. So if he's not allowed to breathe spontaneously, he's supposed to be kept on paralysis. This is the reason why, because you end up paralyzing these patients a lot. This is the reason why control mandatory ventilation has slowly been pushed out of the favor. So what is assist control ventilation? Assist control ventilation is we allow the patient to trigger his breath. This is what is assist control ventilation. Look at the graph on the left side of your screen. Okay. Now, if you look at the pressure time graph, the pressure time graph, you see a negative deflection downwards. I think the first and the second graph, you see that there's a negative deflection downwards. That is the patient trying to trigger his breath. Once he triggers the breath, the ventilator will assist it and achieve the target volume that was supposed to be achieved. This is what is called assist control ventilation. So it can be patient triggered or it can be time triggered. Control is purely time triggered, whereas assist control allows the patient to trigger his breath. So the patient worker breath is very small if a trigger is set accordingly. It allows the patient to control his respiratory rate or minute ventilation and to normalize the PCO2 values. Now, what would happen in this mode is, if you allow him to breathe, he'll start fighting with the ventilator. So there is a chance that these patients who can go into asynchrony. So these are the patients who can go into patient ventilator asynchrony. So when you put somebody in assist control ventilation, make sure you sedate him well. Or if he's good enough to be taken, you can shift on to the next mode. This is one mode which was very much in demand, let's say around 5 years back, but slowly, since there was a landmark trial which was done, and slowly it's being pushed into the corner. This is one of the most common modes used by the anesthesiologist post their surgeries to wean them off slowly from the ventilation. Now this is a mode where the patient is allowed to take his spontaneous breaths. He's allowed to take his breaths, and there are preset breaths as well. That is, you keep a particular rate and you keep a particular time. You allow the time triggered breaths, and you allow the patient to take his breath also. Now then, how is this different from assist control mode? Look at this. In the assist control mode, you find on the right side of the screen, on the assist control mode, the patient triggers a breath by causing a negative deflection, but then the volume achieved is what you preset earlier. Let's say I preset a volume of around 400 ml. The volume is around 400 ml that is achieved. In SIMV, if you look at it, the first breath happens to be a patient triggered breath itself. You achieve a target of, let's say, 500 ml. But the next two breaths, you don't keep a target of 500 ml. You don't keep it volume. You allow him to breathe whatever he can and just support it mildly. This is how SIMB is different from assist control mode. So it sounds very good. That is, you allow the patient to breathe on his own. You allow his diaphragms to work, and you expect, theoretically, you expect it to help him wean off from the ventilation. But there were trials done, and they said that SIMB is not a good mode. One reason being, you end up, paradoxically, you end up increasing his work of breathing, and you unnecessarily put a patient on an SIMB mode, and then you put him on a pressure support mode, and you delay the extubation for these patients. Okay. So that comes to the point. Then what mode do you put a patient on before taking him off ventilation? Now you've got the controlled mandatory ventilation, which is completely out now. You've got the assist control ventilation, which you start off the ventilation in. Once you feel that somebody is, you achieved the targets of ventilation, your X-ray is better, his FiO2 is improving, his lung is ventilated well, then you've got to start making plans of taking him off the ventilator. And you've got to be sure, is this guy good enough to be taken off the ventilator? How do you know that? That is the spontaneous mode of ventilation. Now, what is spontaneous mode of ventilation? To be very basic, spontaneous mode of ventilation is you allow the patient to take his own breath. You allow him to decide what amount of breath is supposed to be taken, and you just support his breath. So what do? I put him on a particular amount of people, let's say around 5 centimeters of water, and I give a support of, let's say, around 10 centimeters of water. So he would generate a volume. If you don't give him any support, to generate a volume of around 100, 150, but that's not enough for me. I want more. So I support it with another 5 or 6 centimeters of water, and I try to achieve the target of around 400 to 500 ml. So how is the spontaneous mode different from the control mode? The spontaneous mode, every breath is triggered by the patient himself. It is not a time triggered thing. It's not that every 2 seconds a breath is given by the ventilator. No, it is a mode where the patient starts his own ventilation. He decides his rate. Only that every breath that he takes is supported by the ventilator. That's all. So if somebody is holding on very minimal supports and a very minimal PEEP on the pressure support mode, let's say on 30 minutes or 40 minutes, and he's good enough to be taken off the ventilator. So it's a weaning mode. So it provides an inspiratory flow to the patient in form of the pressure support, the flow adequate to fulfill a patient's inspiratory demand, and it retains the PEEP that is to be given to complement a patient's inspiratory effort. So these are all the modes that I've given. I just very, very short try to tell you. Assist control mode is a volume limited. There are volume limited and the pressure limited. Your PSV is more of a pressure limited mode. Look at the triggers. Or in the assist control, trigger is by both the ventilator and the patient, whereas pressure support mode, it is only patient triggered. That's all you got to remember in this mode, in these modes of mechanical ventilation. Okay. What are the factors influencing the choice of which mode is to be given? Like I told you, I generally prefer the volume control mode of ventilation because I'm very much accustomed to it. I know about the mode in and out, so I prefer the volume control mode. But there are conditions where you've got to make tweaks and changes in the volume control mode. There are conditions where you might require a pressure control mode. So if the one factor happens to be the level of support that's needed, the proportion of ventilator support that is met by the ventilator. So in case of respiratory failures, I would always prefer to keep him on an assist control mode of ventilation. Let's say pneumonia or ARDS, I would always prefer to keep him on assist control mode first. Take his ventilation in my hand, keep him on that ventilation, and then slowly switch over to the spontaneous mode of all other modes. The reason for mechanical ventilation, let's say in case of ARDS, again, I would prefer an assist control mode of ventilation, but I have particular targets. I would rather keep him on a low time because these are the patients who are going to be on a ventilator for a pretty long time, maybe around 5 or 6 days, and they're going to be ventilated with high pressures. I expect ventilator-induced lung injury them, so I would keep a low tidal volume. That's around 4 to 6 ml per kg in these patients. In conditions like I told you, where you have airway protection as the important cause for mechanical ventilation, in these patients, I would, till the initial paralysis that was given to intubate the patient, after that paralysis weans up, I would like to put him on the pressure support mode of ventilation as soon as possible. Why? I would like his diaphragm. I like the patient to take care of his own ventilation, and I like his diaphragms to function well. So in these patients, I'd rather switch them over from the assist control mode to a pressure support mode as soon as possible. Conditions where airflow limitation happens, like in COPD or asthma, It's the volume limited modes that are more generally used, because these are patients where I would like to have these are conditions where the ventilation is an issue more than the oxygenation. So in these patients, I would like to keep a particular tidal volume and have a better control on my PaCO2 levels. So these are patients where I would like to keep volume limited modes. Now, this is a relatively rarer condition where there's an air leak, like where you have alveolo-pleural fistula. The thoracic surgeons are very much used to this kind of conditions where you have alveolo-pleural fistulas or a bronchopleural fistula where there's going to be a certain amount of leak. In these conditions, I would prefer a pressure limited condition. Why? Because no matter how much of volume I give, the more volume I give, the more volume leaks out. So I would like to keep the patients initially on a pressure limited condition and switch them over to a pressure support mode of ventilation to reduce the amount of leak. Because more and more volume I give them, more and more pressure I give them, that will only continue to leak through that particular air leak that is there in the lung. Now, mode specific. Now, since you've decided, now I've decided that I've got an ARDS patient, I would prefer a patient with volume control mode of ventilation at a particular tidal volume. Now, what are my settings that I'm going to prefer? Tidal volume. Tidal volume is the amount of air that is delivered with each breath. We generally have the volume control mode that is being given. Now, how much of volume do I decide on a patient? Generally, the amount of volume decided is universally, it has always been 4 to 8 ml per kg. Earlier days, I would say somewhere before 2000, it was standard, keep more than 10 ml per kg. More volume you give, the more PaCO2 gets washed out, better ventilation, good enough. But then there was, yeah. So then there was a situation wherein there was an ArdsNet trial that was done in 2000, and it was a landmark trial where they said, okay, the more the volume you give, the more the ventilator-induced lung injury happens. So bringing down the volume is supposed to be the norm. So how much do you bring the volume down to? Let's say around 4 to 8 ml per kg. We prefer around 6 ml per kg of predicted body weight. The reason why you use predicted body weight is because it's not possible to weigh a patient on the who's in the ICU. So you have beds which weigh you. If you don't have those beds, there's a particular formula also for to predict the body weight. This low tidal volume is the low tidal volume is what we prefer in all these patients. This is the only one that showed any sort of mortality benefit in ARDS patients. So you set a volume of, let's say, around, I decided. So I keep a volume of, let's say, around 300. I've decided my predicted body weight to be around 380 ml, and I've kept a volume of around 380. Now, how do I decide that particular volume is enough or not? I keep that particular setting and I look at my ABG. I look at my PaCO2 levels. If the PaCO2 levels are not what is expected, then I have, if I have not reached my 8 ml per kg, I can increase the volume a little bit more. This is how we decide on what volume to be given. Now, what is the problem when you give too much of volume? There is barotrauma, there could be intrinsic peak. You might end up causing hyperventilation in these patients. And you might also lead to a respiratory alkalosis. If more than required volume is given, the patient might end up in respiratory alkalosis also. If you give too low volume, what would happen? The patient would end up in lung collapse and alveolar collapse and atelectasis. So tidal volume, take home points, 4 to 8 ml per kg of predicted body weight, and look at the ABG levels, look at the PaCO2 levels, and then decide whether you can increase it, but do not go beyond 8 ml per kg body weight. Now, next is the ventilator rate. How much of rate do I give? The normal ventilator rate, what is the normal respiratory rate? It's around 12 to 18 breaths per minute. So rationally, if I put somebody on a ventilator, I would rather prefer to keep him around 12 to 16 breaths per minute. Now, the main parameter that decides what ventilator rate to keep for a patient is how was he before intubating. If he was somebody who was tachypneic, he was breathing at rate, let's say, 30, 35 breaths per minute, there's no point in keeping him on 12 to 15 breaths per minute. I would rather keep a higher rate of around 28 or 26 breaths per minute. But if he was somebody who was intubated for unprotected airways, I would rather keep him on the most physiological rate, that's around 12 to 16 breaths per minute. More than 35 is not acceptable. Now, what happens in these patients? If I keep too much of a rate, our is to E is around 1:2.5. For a normal person, we give, if 3.5 seconds happens to be our one respiratory cycle, we reserve 1 second for inspiration and 2.5 seconds for expiration. If I keep somebody on 35 breaths per minute, what would happen is, before the patient is able to expire himself completely out, I start the next inspiration. So what would happen? There'll be a lot of air stacking into his thoracic cavity. When a lot of air starts stacking in his thoracic cavity, slowly the pressure increases so much that there'll be no venous return at all. RV failure happens and the patient collapses. This is what is shown in this. This is what is called autopep. Now, what happens in this patient is, this is typically seen in asthmatic and COPD patients. Asthmatic and COPD patients, like I said, our normal inspiration expiration is on 1:2.5. In asthmatic and COPD patients, they generally have around 1:3, 1:4, 1:4.5. If you put a high rate in these patients, what would happen is, before their expiration is completely done and dusted with, you'd start the next inspiration. And for every breath, you end up stacking a lot of air. Now look at this graph. The blue lines, the lowermost line, that is a volume time graph. Look at the baseline. Before the triangle hits the baseline, the next breath starts. As you look from the second second to the fifth second to the seventh second, there's more and more gap in the baseline. That's the amount of air that is stacking in the patient. So when the intrathoracic pressure reaches a particular threshold, there'll be no venous return at all. The patient will go into cardiac arrest. This is a very common real life scenario that happens. Asthmatic patient comes to you, tachypneic, tachycardic, he goes into respiratory fatigue, you decide to intubate the patient. Somebody who doesn't know the basics of ventilation, he ends up keeping a rate of around 25 breaths per minute or 24 breaths per minute, 1:2 ratio, 400 ml of tidal volume. The heart rate comes down, oxygenation comes down, patient collapses, goes into cardiac arrest. This has happened. I've seen this many times happening. During my initial days of critical care, I had an asthmatic patient and he just crashed. So what do you do at that point in time? Nothing. You just disconnect the tube from the ventilator and you give him cardiac compressions and put him back on the tube and put him on an IST of, let's say, around 1:3, 1:4, bring down the rate, allow him to expire properly. This is what you can do. So always when you intubate a patient with asthma, be careful this particular point. Okay. Now, the most important, the reason why people put a patient on mechanical ventilation in an ARDS patient is the PEEP. PEEP is a never-ending dilemma. It's a class of its own. I'll just make it as less as possible. What is PEEP? Like the name suggests, it's a positive end expiratory pressure. That is the amount of air that remains in the alveoli after an expiration is supposed to be a PEEP. So what does that mean? So even on expiration also, even if the patient expires completely, you don't allow his alveoli to collapse. You let a certain amount of air to remain in the alveoli. This is what is PEEP. So PEEP would keep the alveoli open and allow the diffusion to happen. But if PEEP becomes too much, like I said earlier, if the PEEP becomes too much, it would end up compressing the capillaries around it and there'd be no diffusion. It starts defeating the whole purpose. If the PEEP becomes very much, you end up creating a pneumothorax. So it is applied in conjunction with the other modes. Generally, 5 centimeters of water, very safe. For any condition, 5 centimeters of water, very safe. What are two major indications that you would like to increase the PEEP in case of intrapulmonary shunt or a refractory hypoxemia? Intrapulmonary shunt would mean my alveoli are flooded because there's a pneumonia or there's an ARDS, my alveoli are flooded. Even though the pulmonary capillaries are flowing very well around it, I am not able to cause diffusion of air. So what would I want? I would want my alveoli to expand beyond 5 centimeters of water. That is where I give PEEP for these patients. So when you give PEEP, you have more area that is ventilated, more area that is more diffusion happening, it will improve the FRC and improve the lung compliance. So PEEP by definition, it reinflates the collapsed alveoli and maintains the alveolar inflation during exhalation. Once the alveolus are properly recruited, it maintains gas diffusion and oxygenation. Now, what would happen if I keep too much of PEEP? It would decrease the venous return. PEEP is a pressure. So PEEP itself would cause barotrauma. PEEP beyond 10 centimeters of water would also lead to increased ICP. Why? Increased intrathoracic pressure, decreased venous return from the brain can also lead to increased ICP. So how does PEEP affect the hemodynamics? Again, PEEP would decrease the preload to the left ventricle. It will also decrease the LV afterload. So we always say, you keep too much of PEEP to a person, the renal return will decrease, the patient will collapse. Don't keep too much PEEP, don't keep too much PEEP. But that happens only if your patient's volume is very low. If you give too much of PEEP to somebody who's hypervolemic, to somebody who came, a trauma patient comes to you, he's hypervolemic, he's somebody who's bleeding. You give 10 PEEP to that patient, he would collapse. His return would decrease, his BP would crash downwards. So always, when you decide to give PEEP to a patient, make sure he is euvolemic. Look at his IVC, look at his general hydration status, make sure he's well volume loaded, and then you give him the PEEP. Only then would PEEP, if a euvolemic patient, PEEP generally does not cause a hypotension. FIR2, although it sounds to be the most important thing, it's the easiest thing to be done. You have oxygen goals that are individualized. Generally, FIR2 is the fraction of inspired oxygen that is given to a person. Never try to maintain 100% saturations. It has been proved beyond doubt. Okay, maintaining 100%. There's a landmark trial called if you would like to read up, you can read up. It's called the ROCKS ICU trial, where they said that keeping beyond 98%, trying to hit a target of 100% only causes more redox injuries and free radical injuries. So do not try to maintain saturations around 100%. Now, if you keep somebody on 21% and he's still maintaining 100%, you can't do anything about it. But do not try to maintain saturations around 100%, especially in post-cardiac arrest patients who are ventilated. It's been proven that maintaining saturations around 94% is acceptable. Beyond 94% actually increases the mortality. Hyperoxia is generally avoided. And then oxygen itself is a medicine. Oxygen itself can cause atelectasis by denitration and all that. There are conditions where you would like to keep 100% oxygen. Those are conditions like carbon monoxide poisoning, where you would like to increase the carbon dioxide concentration and allow the hemoglobin to dissociate from the carbon monoxide. Air embolism, sickle cell crisis, and not an intubated patient. Otherwise, other patients you would, other pneumothorax, not an intubated pneumothorax, other pneumothorax patient, you would like to keep a higher oxygenation. What's flow rate and pattern? Flow is the speed at which air is delivered to a patient to a ventilated patient. What are the, generally in the volume control modes, you generally keep on, this is something that could be set on the ventilator itself, and it is decided by the I/E ratio. You might not find a flow parameter on the ventilator. It is generally decided by the I/E. Now, if I keep somebody on I/E, I generally keep somebody on I/E of 1:2. If I keep him on I/E of 1:4, what will happen? My inspiration time is reduced, but I have to deliver a volume of around 500. So I would deliver that 500 at a very fast rate. That is where you give higher flow rates. That's where flow comes in. So generally 40 to 60 liters per minute of flow is enough, but there are conditions where I would prefer a higher flow rate. Those are airflow limitation conditions like COPD and asthma. I would keep a higher flow rate of around 75 liters per minute, because those are patients who take deep breaths and they give exhalation over a particular amount of time. So those are patients who got air hunger, and in them, I would like to keep a higher flow rate. So then if you can give a higher flow rate to COPD patients, why not give the same flow rate to a person with ARDS? No. High flow rate comes at the cost of increased airway pressures and barotrauma. So I would rather reserve the flow rates for patients with COPD and asthma. Above 80 is generally not required. See, look at this. This is the graph of these are all ventilator graphs that I'm showing. These are not my own graphs. Look at A and look at B. This is look at the pressure time graph at the lower down, PAW by time. You look at the graph, it's a very smooth upward curve and a smooth downward curve. You look at the same corresponding graph on the B side, the right-hand side. Slow increase, and the patient tries to pull himself and lead to an upward. This is a case where there's an air hunger. The patient requires more flow. This is one way you can look at the graph and say, no, I would like to keep a higher flow for this patient. This is one way to look at the graph. Now, what are the flow patterns? This is just for completion's sake. There are different flow. There's a square flow pattern. There's a decelerating, accelerating sine pattern. All over the world, we generally prefer a decelerating pattern of flow, wherein the flow is given much faster initially, and then you slowly bring it down. So, a couple of words on trigger. Okay. Now, like I said, trigger is what decides the next breath. Okay. Generally, we have time triggered breaths. Now, what exactly? Now, there are also flow triggers and pressure trigger. Now, when you look at the ventilator, now these are all just words that I put in, but to be simple, trigger is, if I keep somebody on negative pressure trigger, generally we keep a trigger of around -2 centimeters of water. So that means this patient has to create a negative pressure. He's supposed to create a negative pressure around -2 minimum for the ventilator to allow him to take a breath. A real life scenario is people put the patient on the ventilator. The patient is trying to breathe. He's not able to breathe. He gets panicked. You're not sedated him properly. The ventilator is not allowing the patient's breath. When you look at the parameters, when you look at the advanced settings of the ventilator, you find that somebody has kept a trigger of -6, -6, -7. This is one way. If the patient goes in extreme synchrony, this itself can lead to a cardiac arrest. So you would like to keep the trigger at around -2 centimeters of water and allow him to breathe with that trigger. So these are the initial settings of every patient on invasive mechanical ventilation. Tidal volume, I would rather keep at around 4 to 8 ml per kg body weight. I would rather start off with 6 ml per kg body weight. If I'm not able to maintain my PaCO2 levels, then I'd rather increase to 8 ml per kg body weight. Even on 8 ml per kg body weight, I'm not able to maintain my PaCO2 levels. Then I'd come down. Then I'd use another parameter. I would not go beyond 8. I would not go beyond 8. Then I'll use another parameter. I'll use the ventilator rate. I'd start off with 12 to 16 breaths. I've put him on 8 ml per kg body weight. I'm not able to maintain my CO2 levels. I'd rather increase the rate, provided that rate does not lead to an auto PEEP. PEEP, I would rather keep on a very safe level of around 5 centimeters of water. But if it's, let's say it's an ARDS patient, I want better oxygenation. I'm not able to maintain my oxygen levels. I would rather increase my PEEP from 5 to a safe value to a maximum of 10. Beyond 10, always use help to go beyond 10. Don't go beyond 10. Because beyond 10 is where hypoventilation, hypotension, increased ICP, risk of pneumothorax, all these things happen. If I had to target, I just look at my SpO2 levels. If my SpO2 levels are around 92 to 96%, I'm very happy. I don't want to go beyond it. Inspiratory flow or inspirate I/E ratio, the most safest ratio is 1:2 ratio. But like I said, in patients with COPD and asthma, I would rather keep them on a higher expiratory time of, let's say, an I/E 1:3, 1:4, and keep them on a lower rate of around 12. So I allow an I/E to happen also. If I keep somebody on 30 rate and I keep them on I/E of 1:4, not possible. The inspiration would happen in what? 0.025 seconds, which is not possible. It leads to a lot of bad trauma. Trigger sensitivity, I would keep around -2 liters per minute. Now, these are all the parameters of the mechanical ventilator. General care, once you put somebody on a ventilator, it's a very rather inhumane thing. There's a lot of difficulty for the patient. I would like to keep him on good sedation along with analgesia. Generally, we prefer drugs like dexmedetomidine or fentanyl and delirium management. So delirium is something that can happen in these patients. So we would always prefer not to use drugs like midazolam. There's a landmark that is done called the DEXAM trial where they had compared dexmedetomidine with midazolam, and they found that patients on midazolam were found to have larger rates of delirium. So I would rather prefer drugs like propofol or fentanyl or dexmed. Dexmed is the most safest drug. Hemodynamic monitoring, like I said, once you start somebody on a ventilator, you give him positive pressure ventilation, his BP can crash down. Okay. So I would make sure he's enough volume loaded. Nutritional support. These are patients on a ventilator. They're critically ill. They have got a very high catabolic rate. You would keep a nutrition target of around 25 kilocalories per kg food. This is the general allowed rate. If you keep them too high, if you keep them on 35 kilocalories per kg, you would have larger carbon dioxide production. There'll be a lot more carbon dioxide production, and that ventilator would have to take care of the carbon dioxide as well. So don't keep them on very high nutrition targets. If you under nutrition, if you don't provide them adequate nutrition, their muscles will get wasted, and you would not be able to wean them off the ventilator. So a safe target would be around 25 kilocalories per kg, but around 1 to 1.2 gram per kg of protein per day. Good glucose control, 140 to 180 as per the NICE guidelines, 140 to 180 milligram per deciliter of sugars. You would like to prevent VAP. Now, I'll take a couple of seconds on this. VAP, the minute you decide to put somebody on the ventilator, your target is to take him off the ventilator. Of course, oxygenation, carbon dioxide, ventilator, all these are true. But one of your targets should be take him off the ventilator as soon as possible. Why? Because ventilator itself would lead to ventilator-associated pneumonia, which happens to be one of the complications. Now, how does VAP happen in these patients? Like you intubate a patient, he's got a cuff around the tube, encircled by the trachea. Always these patients have a tendency of microaspiration. All your oral flora, whatever you do, how much ever pressure you give also, there will be some amount of aspiration, especially in patients who are restless on the ventilator. They get very restless and there'll be increased aspiration in these patients. So to prevent VAP, always try to take them off the ventilator. There are VAP bundles customized for each universities and hospitals around. Generally, the VAP bundles that are used are stress ulcer prophylaxis, DVT prophylaxis, sedation holidays. Every day morning, you take him off the sedation and you give him a pressure support ventilation trial. Ventilator patients initially conditions like ARDS. You can't mobilize a patient on the ventilator. It's one of the biggest drawbacks of a ventilator. You can't mobilize them. So invariably make sure you put them on venous thromboembolism prophylaxis, either if the kidney allows you, you can start them on low molecular weight heparin. If the kidney doesn't allow you, you can put them on unfractionated heparin based on the creatinine clearance. Stress ulcer prophylaxis with a pantoprazole of around 40 mg IV OD would be enough. Venous arterial access and temperature management. That's all I've talked about. Just summarize, it is defined as a delivery of positive pressure to the lungs via an ET tube or a tracheostomy tube, most often used to fully or partially, fully in the form of assist control mode of ventilation or partially in the form of pressure support ventilation, partially replace the function of the lung. There's no universal nation mode. Someone comes and tells you pressure control is better or volume control is better. He is just not doing the right thing. Whatever mode you and your team are comfortable in, that is the mode to be used. Once a mode has been selected, let's say volume control mode, tidal volume of 6 ml per kg of predicted body weight. There is a formula for predicted body weight, 45.5 plus 15.3 in kilogram inches minus 60. Height in inches minus 60. It's available all over. A respiratory rate of 12 to 16 breaths per minute is what is universally told, but it all depends on where did you intubate the patient? Was he tachypneic when you started intubating him? Then I'd rather keep a higher rate. Was he an asthmatic? I'd keep him on a lower rate. Was he intubated for securing the airways for a traumatic brain injury patient? I'd keep him on a physiological rate of around 12 to 18 breaths per minute. PEEP, I'd always start with 5, depending on the condition. If it's an ARDS patient, I'd rather keep him on a higher PEEP, but always take help when you go for a PEEP beyond 10 centimeters of water. FiO2, my target is 92 to 96% saturations. Peak flow rate around 60 is enough, and IST 1 is to 2. If conditions like you encounter conditions like COPD or asthma, I'd rather keep a higher peak flow rate of around up to 80, not beyond 80. Trigger sensitivity, always remember, if you feel that the patient is struggling on the ventilator, he's not able to take his breaths, look at the trigger. Somebody must have fiddled around the ventilator and kept a trigger of minus 10 or minus 15. So keep the trigger at around minus 2 liters, minus 1 to minus 2 centimeters of water. Pressure control mode, I haven't gone much into pressure control because volume control is what I'm talking about over here. Pressure control is basically you keep a particular pressure and you look at the amount of volume. So what happens is when you keep somebody in a pressure control mode of ventilation, you keep a particular pressure, let's say around 20 centimeters of water. So your target is generate a particular tidal volume. If I keep him on 20 centimeters of water, when I'm looking at the patient right now, he's generating a tidal volume of, let's say, around 350 ml of volume. As time goes, the ARDS patients' compliance will improve. So when you keep them on 20 centimeters of water, maybe tomorrow his compliance improves. So today he's producing on 350 ml volume. Tomorrow he'll produce on 450 ml of volume. So you're actually creating more damage to the lung. So the problem with pressure controlled mode of ventilation is you've got to be vigilant. You've got to keep looking at the ventilator. You've got to look at the monitor. If he's generating higher tidal volumes, you've got to come down the pressure support, inspirative pressure to giving him. Select population deserves special attention, including patients with ARDS, airflow limitations, traumatic brain injuries, and patients with air leak. Supportive care also should be addressed. Thank you.
Thank you, Dr. Sajid, for the excellent and very informative talk on mechanical ventilation. And the topic is open for discussion.
Oh, yeah. That's called the subglottic suctioning. Now, what happened? Like I told you, what is the main reason for VAP that happens? It is now I put a tube, let's say I put a tube for the patient. This is into a trachea. There's a cuff around over here. Whatever you do, there will be. Now, what is the reason for VAP? The secretions that are above the cuff, which over time slowly will start aspirating around the cuff and downwards. So when you have a subglottic suctioning, the suctioning happens above the cuff. And when you suction that out, your chances of microaspiration are even more reduced. This is proven to reduce the incidences of VAP. So it is always preferred to intubate patients with subglottic suctioning, provided you expect him to be on the ventilator for more than 2 days. Okay. Now, if you're intubating, like I said, one of the indications for intubation happens to be your bronchial suctioning or bronchial toileting. I'm going to intubate him today and I'm going to extubate him tomorrow. So in these patients, I would not prefer a subglottic because it comes at an extra cost. But in patients whom you're expecting the patient to be intubated for more than 48 hours, where the VAP happens also. If I'm expecting him to be intubated for more than 48 hours, I would prefer endotracheal tube with a subglottic suctioning as a measure to reduce the incidence of VAP.
Surgical, you said about barotrauma. Okay, patient coming to the casualty. You're going to intubate the patient. Then, when you're going to intubate the patient is having barotrauma. You will have to. You are well trained to put in a tube or something like that. What I want to convey the message is that in this August audience, even I am I'm not very much well trained about all this, but when to intubate and when to ventilate. When should we ventilate and when should we not ventilate?
Okay. That's a topic that comes for, like I said, specific populations. Now, my slide on the indications for ventilation. Let's look at it as patients with unsecured airways. If a patient with traumatic brain injury comes to you, his GCS is low. Initially he was maintaining his oxygenation levels. He was ventilating himself. I take an ABG. His PCO2 levels are holding on. His PO2 is holding on. There's no big issues. Next day I see he's got an OT requirement. That means what? He's aspirating. Today is only 1 liter per minute. Today it's only a basal collapse. I don't want him to go further worsening. So in these patients, I am justified in intubating that patient. This is the case of unsecured airways. In a person with ARDS comes, a lady who came with ARDS. She was tachypneic, she was tachycardic, she was hypoxemic. She was hypoxic on room air. That does not mean I put her on intubation mechanical ventilation. I give her a trial of HFNC. I give her a trial of, if required, a short trial of NIV. My PO2 by FiO2 ratios or my oxygen levels or my oxygen requirements are increasing. in spite of my non-invasive measures of ventilation. And the patient is going into respiratory fatigue, or the tachypnea is persisting at around 35 to 40, in spite of all that I've exhausted my non-invasive methods, then I'm justified. So what is the objective parameter over here? I always use my ABG and my respiratory rate. If my ABG shows worsening PO2 levels, or the PO2 levels are still stuck at the same level that it was when I started our non-invasive methods, I'm justified. If my respiratory rate is 35 before starting our non-invasive methods, continues to be 35 even on starting our NIV methods, then I'm justified.
If your ABG levels, potassium, is around 6, and she is having a difficult airway, will you give scoline and intubate?
Now, first of all, I would like to look, why did the patient develop hyperkalemia? Second thing is, I would not paralyze her. I would put her into deep sedation and induction, make sure she's ventilating well, and then I take a call on.
Different. He's having a hyperkalemic state.
I can't give scoline.
And she's having a Mallampatti score of around more than 3 or 4. Then will you give scoline and intubate?
No, I wouldn't.
Then how will you secure the airway?
Yeah, the two ways of looking at this. One is I would rather keep on higher sedation, higher paralysis, higher sedation, and higher dose of induction. Second thing, what I would do is I would keep my adjunctive methods. Now, intubation via direct laryngoscopy is not my only method. I have bronchoscopy. I have laryngeal mask airway. I have my tracheostomy kit also ready with me always. Well, it would be enough. That is when I take up my call for tracheostomy, for an cricothyrotomy for an emergency airway.
Nowadays, so to answer your question, I'm also colleague of him. Nowadays, we have a Sugamadex available. So even you can use rocuronium even in difficult airway patients. Yes, if scoline cannot be used in such situation because of hyperkalemia, but you can use rocuronium if you have Sugamadex available, which is a reversal of agent. Immediate reversal can be achieved with our center now has Sugamadex. Very few centers, but now it is possible in India.
Dantrolene. I think those are their names as far as I know. Yeah. Now, although SIM, to be no, to be true to you, I myself use the SIMA mode, to be frank, but very selected cases. Like I say, let's say obesity hyperventilation syndrome, I've put the patient, I don't want the patient to be in SS control mode for too long because her diaphragms are already weak. I don't want her to, and she's not fully conscious enough to start her on pressure support mode of ventilation also. So in these patients, to transition from an SS control mode to a pressure support mode, I put them on SIMB at a very low rate of around, let's say, 10 breaths per minute and keep on higher support. So I mean, if you ask me the evidence for that, there is no evidence. But on my small experience, this is what I do. To transition them from an SS control mode to a pressure support mode, I give them a very small time of SIMB mode of ventilation. You can, but it's more safer when there is no. When there's no continuous monitoring that's happening, then SIM is relatively safe for this particular population. Yeah, 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 correct. Yeah. Yeah, yeah, yes, yes. Yeah, yes, yes. Yes, sir. Now what was the indication for ventilation with question comes? Let's say if it's a traumatic brain injury patient, I'll give you particular scenarios. Traumatic brain injury patients. Traumatic brain injury, my indication happens to be securing the airways. So I would rather put him on a volume control mode of ventilation, and I would keep him, try to transition him to a pressure support mode as soon as possible. Keep him on most physiological settings. 6 ml per kg body weight, a rate of around 12 to 16 breaths per minute. As long as my targets are maintained, I'm happy. My oxygen targets? Yeah. Okay. So why was I not, first question is, why was I not able to maintain my oxygenation targets? Was there a lung injury that was involved? Was there a contusion? Was there any ARDS? So I would rather, if my FiO2 is around 100%, I'm only maintaining around 90% or 86%. I would rather increase my PEEP. I would like allow alveolar recruitment, increase my PEEP. That's exactly what I'm trying to tell you. What my slide I told you, if the patient is not euvolemic, I cannot increase my PEEP. I've got to give him volume. On one side, if he's bleeding, I'd rather secure my bleeding patient. On the other side, I give him more volume and then increase my PEEP.
Next is vote of thanks by Secretary.
So my take-home message to everybody who's working everywhere, these are the basics that are used. Okay. If you feel that a patient has to be ventilated, do ventilate him. Do not allow him to be transferred without ventilating to another center. You're wasting very important time over there. When you start them on ventilation, decide why are you ventilating that patient? What is your indication for mechanical ventilation? And decide on the settings based on your indication for mechanical ventilation. This would be my take-home message, and that's all. Yes, sir. Yes, sir.
Our sincere thanks to Dr. Sajid.
Thank you, sir.
Excellent and
Thank you, sir.
informative talk on mechanical ventilation.
Thank you, sir.
All members for attending. Thank you.